Welcome to the Homegrown Heart Podcast, brought to you every Friday morning at 7 a.m. Mountain Standard Time, with your host, Dr. Amanda Ryan, D.O., MBA, interventional cardiologist, and a recognized expert in her field. This week's topic, rural healthcare in crisis. Please help me welcome our host, Dr. Amanda Ryan.
Good morning, Carlsbad, Eddy County, listeners in Illinois, Florida, and thank you for all your continued support here at the Homegrown Heart. I'm in studio with Danny Fletcher. It's Saturday we're taping this week because, well, being on call, got a little delayed yesterday, but all the patients are fine, and that's what counts. I really want to use this morning for a brief PSA. I'm realizing sometimes the way people are following my TikToks, that Lady Heart Doc for Life, a lot quicker than they're picking up on some of the podcasts. And I think sometimes that is our attention span. And just that we're so consumed as Americans with all our other responsibilities that sometimes brief things, go over a little better. The issue is cardiology and health equity, women in cardiology, so many of the different topics we cover, it's hard to cover them in a short period of time. But hopefully what we do say leaves you interested in going and learning more about that, empowering your own health, that of your family, really realizing when you have a chance, whether even it's elected officials, to really make a difference in voicing your concerns about healthcare, or if there are things you think are going well, things you think could go better. Again, we've all really have to be active in that in order to move the needle enough to create change. There's a lot of push for shiny new buildings in healthcare. And again, 1619 Skyline Circle, Suite A and B, which is our ASC, and cardiovascular practice here in Carlsbad are certainly state-of-the-art. Shout out to R12, beautiful facility. However, the beautiful facility is only one step in really creating the kind of healthcare that you need. Again, my mom, Karen Davidson, my sister, Nicole Hausman, they've spent careers in long-term care. Often realizing that shiny buildings might pass things with surveyors even, that older, unkept buildings don't really seem to get the same kind of feelings when you go in. And especially when you're talking about long-term care and your family members are going to have to quote-unquote live there, obviously how it looks does make a difference. It just makes you feel like you don't really care how things look. What kind of care are you giving? However, I've given some very good care in some very old facilities. They were very clean and infection control was encouraged. So I think, a shiny new building is a great step. In our rural areas, and again, I've talked on rural healthcare disparities, and as that is one of my true main passions, I'm going to keep talking about that. It's call to action though. Again, we've got to go from acknowledging this rural healthcare disparity in care, and we have to become actionable. How are we really going to change that? I think our current city administrators here in Carlsbad are very motivated to listen to the community. Again, I'm on a steering committee. It is appearing that affordable housing, education, and healthcare continue to be our citizens' three main concerns about their quality of life and futures. I think when we really think about that, again, how are we going to meet those needs? And interesting, there's a lot of relationships between 1, 2, and 3. If we don't have a good education system, it's more of a struggle to build our own healthcare force, which being in a rural, remote area, our best chances are truly to build from within. The city and college having that relationship is definitely a good start on that realm. Affordable housing is our next issue. We really have to have where there are some salaries that are skewed in different industries in our region. Healthcare is one of those that isn't really skewed. So we've got average salaries in education, in healthcare, with our EMS, fire, police. I feel like all of those have relatively average salaries comparatively. And then the cost of living is so high in our area, it's just creating difficulty for the middle class family to really continue to thrive in our area. So with that being said, really looking at how are we going to accomplish stuff in each of these. Every new administrator that becomes involved in healthcare in our area, again, has all the answers. Cynthia Madrid, the cath lab manager, director, and myself have laughed several times with different new leaders that come into our community for healthcare. And again, it's good to have fresh ideas. It's good to think outside the box. But her and I and our team of cardiology staff in the cath lab and our practice currently at AHV&M and Advanced ASC have thought and searched outside every box that I think you can imagine. We've turned things upside down, thinking of creative ways to get staff. It's just not that easy. Every time someone's like, well, did you consider this? Well, did you try this? Well, did you reach out to this? Did you go to health fairs? Did you go to education fairs for physicians and nurses and allied health staff in Albuquerque, in Lubbock, in Dallas? Did you do? Yes, we have done all these things. Again, I think I've talked about it before, that healthcare high school that got going in Houston, that Methodist system, I believe, is supporting. That's a very unique idea. I really think we have to continue to get very creative. Carlsbad is growing. Our region is growing. And we may get the financial support to build shiny buildings, which is wonderful. State-of-the-art equipment costs big money and it turns over very quickly. Now, of course, these companies would have you buying the latest, greatest equipment every year. But the reality is every 3 to 5 years, if you aren't investing in your healthcare facility as far as the equipment goes, it does become obsolete relatively quickly. All that costs money. Even if we can get the funds, money, there's state support, we really have to check out all of our options. Even doing all that, the most important part of healthcare is the patient and the staff member. I mean, the staff and the patients are the two most important people in healthcare. That's just reality. We can't do it without adequate supplies and staff, obviously, but we've got to have staff and we have to have trained staff. So I'm working with several different groups and people who are really motivated for this goal in our area as well. How are we really going to continue to meet those needs? We recognize that those needs exist. How can we meet them? Okay, in our practice, and again, we've had a lot of turnover in our practice of nurse practitioners, of nurses, of medical assistants that I really didn't think we'd have. I thought if you build something so special, so unique, with a patient-centered approach and you pay people well and you'll have great staff that are committed. And we do have great staff that are committed. Why did we lose some of the great staff that were committed at one point along the way? I mean, again, and I've talked about this before, some of it is personal, and shout out to everyone who's been on our team. If I've ever practiced medicine and been involved in healthcare with you, and you have a patient-centered approach, I respect you. I appreciate the time you spent making a difference in people's lives. And even if you moved on to a different industry or a different position or any of those things, time spent changing the healthcare of patients, particularly in our rural areas, is time well spent and it's appreciated by everybody. But it's really hard to provide that kind of healthcare in a rural area where, again, we've got one specialist compared to a suburban or urban area that has 30 specialists for the same patient population. I'm not even sure how that's even possible. Our primary care shortage is huge. Our OBGYN shortage, huge. We meet a lot of those needs with nurse practitioners having full practice rights in New Mexico, and that's certainly a good plan. We still, even with that plan, have a complete shortage of providers in our area. So health equity, we talk about it. What does it mean? Medicare and CMS often lead the way for different screening approvals and different programs that are trying to identify problems before they become more and more serious. I always tell people it's kind of sad that, often screening things and health equity stuff starts with our Medicare population, which is primarily 65 plus in the United States. Many times private insurers will follow eventually, but our place to really make that screening and health equity gap differences often starts in our children, our youth, our 25 to 45-year-old population. Disease prevention efforts have to really start earlier. Even as consumers of healthcare, what do most of us, 20 to 50-year-olds, how do we approach our healthcare? If you're like me, most of us don't go to the doctor during those relatively healthy ages unless we're very sick. We are not really focused on any preventive things. We're not overly focused on health, exercising, eating right, plant-based diets, all the things that could probably increase our longevity and improve our quality of life. Things like really evaluating smoking cessation programs, evaluating our alcohol consumption, and is that truly in a healthy range? All of those things are really important for how we live when we get to that 65 or 70 plus range. So again, this is a call to action. You need to care about your health at a younger age. And from an insurance standpoint, we need to focus on some of these programs at earlier ages as well. So in the health equity program, what do we do out here to reach? What do we do at AHV&M? We take a very unique approach. We have some remote employees who I've worked with for years in Florida, Crystal, Jonique, as well as several members of our local team whose main jobs are truly to try to assist the care of patients as they come in and out of the hospital, as they get referred to other physicians, as they go for treatment in El Paso, Lubbock, Albuquerque, Dallas, Houston. We actually have people that manage things called transitional care, chronic care, principal care management. We screen for alcohol use, we screen for tobacco use, we screen for mental health, we screen for depression. Okay, those kind of programs help us liaison, partner, again, our foundation, Partners in Heart Health. We are trying to partner within our community, within external communities, within our region, to really link those programs together so they can provide the most benefit for our patients possible. Now you might think, well, you're a cardiovascular practice. Is that the best, is that normal? Well, it's normal for a rural area because we have a shortage of primary care physicians. And while we stay away from managing some primary care things just because we flat out don't have time or resources to do so, we do invest in linking people to as many of those resources. And you might think, well, you send me to Lubbock to a specialized cardiologist who's going to do an ablation for my atrial fibrillation and help me get rid of it. Don't you just put a referral on the computer? I go see the doctor does his procedure, he sends me back to you, and that's it? What do you really have to do? Whew. And we could do a whole segment on what it really requires to get all of that pertinent information to that physician to make sure that their staff properly tracks that referral. The patient gets an appointment, gets their approvals necessary from insurance, has the procedure done. We are aware of any medication changes. We get the full report from any procedures as well as that physician's consultation. So then when you come back to us as your primary cardiologist, that we can make sure we have everything updated. Again, there are times when, NMHI is a wonderful system providing a lot of great health care up in our Albuquerque in northern New Mexico. But it is not uncommon to take 10 to 15 phone calls through that system until you really get somebody an actual appointment with the physician. I've talked to many of their administrators, and I feel like a decent amount of that is just the sheer volume that they're dealing with. But we have one person in our office that primarily follows up on things. She could call, and again, they could have 50 referral specialists. So she starts telling the story to somebody like, I'm trying to track this person and they've been referred and we haven't, and it's kind of a trust the process, we'll get to them eventually. But again, we have very anxious patients sometimes that we've done everything we could for their cardiovascular care, and then we're trying to get them to the next level. Even I realize that, again, just so we're all aware, some of those subspecialists can take 3 to 4 months to get into. But even if we could just have an appointment on the books or an acknowledgement that we have received the referral and all the pertinent information, that can often be just a relief to the patient. So now you know that that's actually going to occur. What is the primary reason people are readmitted to the hospital within 30 days of an admission? Medications that are messed up. How do we fix that? There's all kinds of things designed in our electronic health records to make sure that we know what meds a patient went to the hospital on, what they got when they were there, and what they're supposed to be on when they're discharged. But it's very easy. Sometimes that gets confused in the process. Sometimes the patient gets confused. Sometimes the patient just doesn't feel comfortable before they talk to their primary care physician or us about starting or changing medications. So we try very hard within 2 days of a patient discharged from the hospital. This is our patient. Now again, this is if we were notified that the patient was in the hospital, and that's a whole nother issue. But if we know, we try to make sure that we do what's called a transitional care management initial call so that we can see why you're in the hospital, what happened, and what medications you really had, and any changes. That way we can kind of guide you on that. How many staff members work? Again, we're currently serving about 13,000 patients in our practice. I'm going to call about 8,000 to 9,000 of them active patients. And so we literally have a staff of about 40 people. And I would say 35 of them are playing an active role in our health equity management program. This involves creating, if we do your transitional care management and we realize that you're going to require a higher level of care than just a few office visits, can really give you, we might recommend either our principal care management or our chronic care management. Principal care is appropriate for people that have a new concerning diagnosis, had a major surgery like open heart, had a heart attack, have new onset atrial fibrillation. All of a sudden their blood pressure is crazy. So those would be people that would be appropriate. This is expected to last 3 to 12 months, where we make sure that you have access to checking your blood pressure at home, scales to monitor your weight daily if you have heart failure, and access to one of our experts so that they can really interact with you on a weekly and as needed basis so that we can really try to get your medications right, your activity levels right, your diet where it needs to be, all of those things. If you're somebody that has multiple medical problems, we might enroll you, and it looks like these will be problems ongoing for 12 months or more. We might suggest that you enroll in our chronic care management program. Now again, what is the cost to the patient for any of these programs? Average is about $7 to $17 a month of your part. All of these programs, they reimburse a relatively small amount, but they do reimburse from Medicare and some private insurers. Sometimes, like if you're getting home health, these services don't reimburse, and we don't really care. We enroll people that we think are appropriate for the program. Truly not about the financial benefit to the practice. It is about doing our best to provide the care that patients really do need. It doesn't do me any good if I refer you to another doctor. You come back to see me 3 months later, you pay another copay, you sit in my office, and you never made it to the appointment. It doesn't matter if it's my office problem, a fax machine problem, the other doctor's office problem, or really whoever's problem it is. I want you to get the care that you need, and that's why we employ and approach health equity in our rural area the way that we do. Sometimes your main issues are way outside the cardiology realm. Again, depression is very common after open heart surgery, after heart attacks, after any major procedure, but sometimes depression is just exists. Maybe you're a patient in my office really complaining of palpitations and chest pain, and your workup from a cardiac standpoint seems pretty normal. Maybe stress and anxiety, maybe depression are all playing a role in your symptoms. So by doing some initial screenings with our patients that are MAs, they always, we talk about these on every visit you have, if you notice. We have intake exams. Our financial manager, Nikki Cooper, said in Florida when her or any of her kids visit the physician, again, they answer all of these questions at all of their appointments. So it isn't even a directed thing. It's just that we have realized as a healthcare society nationwide that your mental health is so important to your physical health that we've really got to marry the two. I am very happy from a legislative standpoint in New Mexico to see some real input being made on behavioral health expansion of programs. But again, you can expand and pay for all the programs you want. You've really got to figure out how do you get trained behavioral health specialists in our state. So we're making some steps, but training people tends to be very... And on that note, even if you make affordable college, which we have some affordable college options, again, yes, but if you have a working parent that decides to go back and really becomes passionate about healthcare in any one of these realms and wants to go to school, how are they really going to do an 8 to 5 Monday through Friday school program and have their kids and maintain any kind of real even part-time work? It's very difficult. I've seen my mom do it. I've seen some of my staff do it. Our foundation's main goal is to help support some of these ladies. The truth is, but several of them work for our practice, and I'm totally happy to support them. The issue is, if they don't work at all, I don't really have anybody, I don't have enough trained staff in cardiology to do their role while they take off to get their further allied health degrees. It's like this just whole dichotomy of what are we going to do and how are we going to do it. And again, to my colleagues that are in positions that can change these things, I implore you to continue to work with us, to think outside the box, to work in your areas wherever you are, to really find ways, how can we reach the patients? How can we get a more qualified how do we keep refreshed our healthcare staff that we have? Again, the average nursing career is 9 years. All of that work and effort that you go through to become a nurse, and then the average career is 9 years. The average career in bedside nursing in America currently is literally 1 year. What are we doing to our nurses that they last 1 year taking care of patients before moving into administrative paperwork and all kinds of different roles? And those roles are important too. But my goodness, where are the career bedside nurses? And again, they barely exist because we've burned them out. I've been here 10 years. I cannot tell you the amount of med-surg and ICU and cath lab nurses that I've worked with that have been amazing. And I can sit here and list so many of them that are not involved in healthcare at all at this point. And for those of them that are, very few of them remain involved whatsoever with bedside, actual daily care of patients. During COVID, the crisis in nursing really became apparent. Of course, back then, a lot of what did we do? We paid people more and more. And I am here to tell you that money is not the only solution. I've said it many times, but there's no amount of money that gets me out of bed to save people's life in the middle of the night when it's 0 degrees and the wind is blowing and I'm exhausted. It is a deep desire and passion to help people in their most vulnerable moments that gets me and my team out of bed to help you. On that same token, and part of what we try to create in our practices is an environment for people that, again, no matter how busy it is, if you're sick, that you don't come to work. Because you coming to work sick, making everyone else sick, and exhausting yourself, getting sicker so that something that should take 5 to 7 days to get over ends up taking you 6 to 8 weeks. That's not beneficial. 4-day work weeks and even 3-day work weeks, that's something that we work towards. We do our best to get to this 4-day work week. It's, again, ask my staff, we'll call it a unicorn for right now because we sure try. And every now and then we're able to accomplish it. But there is so much work and such a lack of people to do it and so many patients that need care. How do you balance all that? And sometimes when we shut our office down for 2 weeks at Christmas and a week at the 4th of July. That's kind of become our pattern. And are some of the patients upset? I can't tell you some of the messages we get on our phone about how we're not reachable during that time and et cetera. And I am here to tell you that our staff have to recharge. They have to have time to spend with their families. They have to have time for self-care. I have to have time for self-care. Again, my family goes back and forth and I go back and forth from Florida at times. I've got to be able to continue living the life that we've created and feel like I'm giving my family something as well as getting their love and joy that really I get every minute I spend with them. I get complete love and joy every minute I spend with my patients too. This is a passion for me. This is not a job. This is not a career. However, I can't pour from an empty cup and neither can any of our other healthcare workers. So I hope everyone has a great week. I hope you take a minute if you've listened to this to really reflect on healthcare in general, healthcare in America, health equity programs, the workforce in healthcare, and really if you are in, again, any position where you can change something, be that as a patient, as a staff, as a leader, please continue to work with committees, work within yourself, work with volunteer groups, get on committees. Again, fill out this survey with the steering committee for the city of Carlsbad so we can really tell them, again, tell us on the steering committee what are our concerns so that we can help to make our community somewhere that people really want to live. Thank you.